Good afternoon. I know we're near the end here, so I'll try to put some energy into it. I might not be able to match Dr. D's energy, but we'll have a good discussion. So what I'm going to do today is I'm going to talk about the results of the Evanthea trial. It is currently in peer review, so anything that I share, it's kind of the peer review process. We really do have to wait until it's final. So it's results from a preprint that's out there in the public, and that will be sort of the third part. I'll also talk about trying to get context for this audience, because I know people are coming at this from different backgrounds. And I'll talk a little bit about what precision medicine is, how it connects to CIRSx, what the evidence has been to date, and really importantly, how we can actually get this to be available to everybody and covered by insurance. So just a couple disclosures here, that the information in here is from a publicly available preprint. And really, thanks has to go out to APRP and the Four Winds Foundation that has sponsored the randomized clinical trial. These are not cheap to do. The cost was just shy of 8 figures. It's been a lot of work from a number of people to try to get to the standard of a randomized clinical trial. So when we think about cognitive decline, it is the top concern of almost anybody in their late 50s or early 60s. I think 85% of people worry about it. Less than 10% of people feel comfortable about talking to a physician about it because they don't feel like there's anything that can be done. And yet today, with solid evidence that would be accepted by most conventional clinicians and guidelines, at least half of it is preventable. I think it's much higher. And so we have an issue that if we can prevent it or we can reverse it, the clinical impact and the global economic impact of this is enormous. As we've looked at the single bullet theories, amyloid causes Alzheimer's, so let's get a drug that reduces amyloid. My estimate is that there's been about $15 to $20 billion spent from the pharma industry for different generations of monoclonal antibodies. And we will educate everybody today on some statistics and epidemiology. I like to use the Cohen's d as an estimate of clinical effects. Just order of magnitude, when you have a Cohen's d of 1, that's usually about a movement of a standard deviation. So if you had a cognitive score of the 30 percentile, you might move up to the 60th percentile. Probably Dr. Shoemaker's protocol had a Cohen's d of 2 or 2 plus. It was enormous, it was significant, it was clinically significant. You can see it from the back of the room. You don't need 1,000 patients to know that it's gonna make a difference. But in here, Cochrane, which is kind of the purveyors of everything evidence-based, reviewed the data, and they basically said, if there's a signal, it's pretty small. It's like 0.1, which means the statisticians can pick it up, but it's not usually making a clinical difference. If you were here last year, you heard Dr. Dale's keynote presentation, and this is a quote from him, monotherapy will fail. I personally think that precision medicine and the use of multimodal interventions needs to be the standard of care for most complex chronic conditions and most chronic conditions. So let's take something like cardiology, for example. Most preventive cardiologists do agree that there's more than one cause of atherosclerosis, even though their prescription patterns may just favor statins. But if you get patients on statins, you will usually see changes in their atherosclerosis over time. But I think Dale's critical insight was really getting to a threshold effect. You need to fix multiple things in the network before neurodegeneration will change. So that makes it very tough to do a clinical trial if you're just changing one thing at a time. If the biology is such that you need to change 2, 3, 4, 5, 6 things, that's what the biology is saying, so now our methodology has to change. And Dale will tell the story when he was first going to the IRB and he got rejected because the researchers said, well, you can't change more than one thing at a time. And they rejected the application. And then they came to him afterwards and they said, well, I have a parent who has cognitive impairment. Can you help my parent? Because there's a practical reality. And so we need to be, obviously we're here because we care about clinical outcomes and patient outcomes. So this is one of my favorite charts. My training was really in health services research and health policy. I'm a general internist, and I did spend about a dozen years working with health systems on how to improve their outcomes when I was a partner at McKinsey & Company. And so we look at it from a macro perspective and say, what do we care about? We care about outcomes, quality of life, how long people are living, their health span. And unfortunately for the clinicians in us, we see that care seems to only make 20% of a difference. It took researchers a long time to even show that getting health insurance made a difference in outcomes. Medical students feel very comfortable about the behavioral drivers of outcomes, diet, exercise, sleep, alcohol, drugs. And certainly we've had a lot of information about the socioeconomic drivers of outcomes, even though as clinicians sometimes we're not in a unique position to change those, but as citizens we may be able to. But what's interesting and fascinating to me is there's not controversy in the basic science literature about the impact of environmental factors as a driver in outcomes. And so, but there is a blind spot. So when there's a publication in the New England Journal about microplastics in atheromas in the carotids, and you can look at a cohort of people and say when you have microplastics in your carotids, you're doing 300% worse in terms of strokes and ischemic events and such. That's pretty incontrovertible. But the immediate move of the medical establishment is, okay, how do we regulate that? But nobody asks the question, well, how do we get microplastics out of the body? That would be a natural question for a lot of other things. We have this blind spot around environmental factors, and we face it every day as CIRSx practitioners. And it's 30%. It may be even higher. So this is a framework from Dr. Albert Espay, who is a neurologist in Cincinnati, and he's done some great work in setting up what's called the Cincinnati cohort program. But it's basically a program to look at Parkinson's and to basically look at it from the ground up. His theory of the case is that none of these clinical syndromes are really respecting what the molecular biology is, and we really have to kind of build this all from the ground back up. And what we have to do is really understand biological subtypes at a very deep level and ultimately match the treatment to therapy. That's certainly been the case in the cancer world, and it seems like that's going to be necessary in the neurodegenerative world. So how does this look like in practice? Notice that I said precision medicine approach, not precision medicine protocol. And I think that recognizes that there's still some uncertainty around how to implement this in practice. You try to do deep diagnostics. You try to use your best clinical judgment to pinpoint the actual contributors. And I would say just from, we're trying to get the exact data still out of the Evanthea trial, but I would say if you asked how many patients who have cognitive impairment have CIRSx physiology, it's certainly north of 50%. Then you have to match the interventions, and an important aspect of interventions is to figure out both the sequence of what you're going to do and trying to drive to results. We all know that if you do too many things up front, people can get overwhelmed. But I think psychologically, people want to see results, usually by 6 months. Otherwise, they lose hope that this work is going to make a difference. And so you have to reassess and keep going in loops again. So let me talk a bit about the evidence to date that supports the precision medicine approach. And this will be outside of what happened in the Evanthea study. So if you look back, historically, there's been about 11 years of evidence now that doing some type of multimodal interventions or precision medicine can change outcomes in cognitive impairment. The first study was the finger study. This was focused at patients who had high risk factors for vascular dementia. And what they looked at was diet, exercise, cognitive training, and then an assessment of vascular risk that could oftentimes be addressed pharmacologically. And the finger study had no impact on memory. It did have an impact on executive function and processing speed, but I think what's notable here is that there was no environmental component. And I think because of that, within a couple years of publications, there started to be worldwide fingers, interventions across the planet. It diffused very quickly because it kind of fell with the, let's call it, the conventional way of looking at things. The Lancet, this was a very influential article in 2020. And I think what was interesting about this was it was just a synthesis of the literature, but it kind of showed what the opportunity was. They created a very detailed model and basically just kind of ran that through. There's a lot of assumptions. There was no clinical trial around this, but they basically estimated that about 35% of incidents could be modified by basic accepted medical practices, and that if you could get that implemented in the population, dementia would be halved if the onset could be pushed out 5 years. Because so much of this is still aging. And so imagine a world where dementia prevalence is cut by 50%. What I thought again was interesting from our perspective is at the same time Lancet did a commission on environmental contributors to outcomes, and it seemed like those two commissions never even talked, in terms of the linkages of environment. There was a lot of emphasis on outdoor air pollution, but not an emphasis on indoor air pollution. And we saw data today to show how much worse indoor air pollution is. That's been updated in the last couple years to move up to about 45% of dementia cases are preventable with, again, much more of a list of modifiable risk factors, including cholesterol and vision loss, hearing loss. Dr. Isaacson is a researcher who initially trained at Weill Cornell, and he's done a lot of individualized risk reduction for Alzheimer's disease. What's been terrific about his research is that he's really protocolized it in his practice and his research. There's very much of a, if somebody has this, then we will do this. And he developed some very sensitive measures of cognition to show that if you're taking patients who are asymptomatic, that you can improve their cognitive outcomes and slow down decline over time. Again, Isaacson's protocols, for the most part, have ignored either infections or environment. He's updated his research to look at biomarkers now. What's happened in the last couple of years is we can measure amyloid, we can measure tau, we can measure neurofilament light chain. And so those biomarkers can be associated with neurologic injury, and we're seeing that those biomarkers can track individualized risk reduction. And finally, Dean Ornish came out with a study last year that showed that if you take the Ornish program, which is predominantly plant-based and low-fat, with exercise and stress management support groups, that you can get a clinically significant impact on cognition. So you have all of these threads of evidence supporting things. So let's talk about the clinical trial. So the clinical trial was preceded by a pilot study of 25 patients. And in those 25 patients, we found about almost a full standard deviation of improvement when you looked at their outcomes by measurement of either like the Montreal Cognitive Assessment Test, which is called the MoCA, or a CNS Vitals test, which is a computerized test to look at cognition. What was interesting from this audience's perspective is there were a set of people who didn't improve, and almost all of those patients had in common that they were in a moldy house, that they couldn't get the, they didn't have either the resources or the ability to get the house remediated. And the study couldn't pay for the remediation. So I'll talk to you about what we did in this trial. But we found out that the initial pilot had such a large clinical effect that for a randomized trial, the usual people that you have in a randomized trial for most, let's say for most drugs, is around 300 or so. If you have a lot of money, you can do 500 or 500 plus. The statistician said you only need about 70. And the question is why? Well, because the impact of the pilot was so large that you didn't need a lot of patients to show that there was a difference. And so we did 2 in the precision medicine group and 1 for every 1 patient that was in the standard of care group. So the patients got standard of care. We pulled out the guidelines from up to date and just made sure that they got exactly what was written in the guidelines for mild cognitive impairment. 2 things are around this. One is you're recruiting for people who want to be in a trial. And in my experience, 95% of people had heard about the Bredesen protocol and were trying to do some of these things. And so you have to make an assessment of, are you doing the protocol or not? And then the other is, you're going to randomize patients and you're going to say, so they're excited to do change. I tell them, you're going to need to be this is like a part-time job. You're going to need to be dedicated to your health. And then you say, well, congratulations, you have to do absolutely nothing for the next 9 months. You're in the standard of care group. So you can imagine that creates some potential for cheating. And it's just every study has to deal with that. We dealt with that from an ethics perspective of saying, look, we didn't even frame it as the control. You're getting standard of care, and then 9 months later, you're going to get access to the precision medicine, and you're going to get it. You're just going to get it later. So we kind of called it the now versus the later group, so that people didn't feel like they lost the lottery if they were in the standard of care group. So everybody needed a study partner because this was a lot of work, and we've learned from experience, if you have a patient who has cognitive impairment and you're telling them, here's 15 things you need to learn, and they don't have somebody with them to reinforce that, you're not setting yourself up for success. So everybody had a study partner. And then what we did that learned from our lesson in the pilot study is we actually had a team go out before randomization to look at the house and to basically ask the question, is the house a disaster when it comes to mold? If there was a light issue, well, that was one thing. But what we weren't going to do is study the impact of a 9-month contractor delay in South Florida on outcomes. So we did look at that ahead of time. And our clinical outcomes were not changes in amyloid or changes in PET scan. It was clinical outcomes, what patients do care about. So there was really not a big difference between the 2 groups in terms of demographics. And the lifestyle interventions were standardized. There was very much of a protocol. There was a health coach, a registered dietitian, and an exercise trainer that were part of the team, as well as a clinician. And there were interventions around food, to be grain-free, dairy-free, whole foods, organic, getting people to keto. So now it's a really interesting question. You have the Ornish diet that is low fat, and now this protocol is a high-fat diet. So how can both be showing similar changes? And I think the answer is, well, the standardized American diet is just so poor that changes from that are going to be a good, and it will be a very interesting question over time. It would be a great head-to-head comparison of who are the subtypes of people who need high fat versus low fat, things that we don't know yet. Exercise, in all three components, aerobic, balance, and strength. If you could do high intensity, that was fine, but it was not mandatory. Stress, the use of heart math, and then the use of Brain HQ to do constant brain training. And then in the environment, the patients needed to agree ahead of time that they would do remediation if it was necessary, and that wasn't covered out of the research budget. And so we did not have anybody who pushed back or who didn't do remediation this time because of our process. And then we did use a number of consumer devices to really monitor people well. So this was all standardized. When it came to the testing was also standardized in terms of looking at multiple potential root causes. So nutritional, cardiometabolic, hormones, immune dysregulation, infections, toxicants, the environment, gut, and genomics. So the entry data set was very broad and detailed. And there was a decision made in the study that this was not going to be protocolized because of a lot of the controversies in here. Instead, this was clinician judgment around both sequence and treatment. So, for example, some of the clinicians used more herbal protocols, for viruses. Others used pharmaceuticals for that. You have variance in how toxicants were addressed, and that can certainly be viewed as either a strength or a weakness of the protocol. There were neuromodulatory treatments available at certain centers, ranging from photobiomodulation to hyperbaric oxygen to neurofeedback and cold lasers. And here are the outcomes. So let me talk about the numbers first. So these are mainly looking at standard scores on what's called CNS vitals. And usually a change in 15 points is equivalent to a change in a standard deviation. And so you can see, for example, the neurocognitive index in the precision medicine group, which is PM. It moved from a score of 92 to 106. So that's an improvement of 14. And then the standard of care group went down. I'll just, for ease, show you the graphs. I think they're easier to see. So you can see that in general, memory improved and cognitive performance improved over the time period with a cumulative effect each 3-month interval. And then the overall neurocognitive index of the standard of care went down, which would be expected in terms of the natural history of people with mild cognitive impairment. So that looks all well and good in terms of graphs. But let's just let's unpack a little bit of the difference between having, a score of an improvement of 15 points. What does that really mean? I think for many patients that is transformative. It is regaining the use of your brain at a significantly different level. And now we had people who improved a half a standard deviation, people who improved 2.5 standard deviations. There's variability in that. But when you look at the aggregate curves, what you can see is that the impact of fixing multiple things is significant. We didn't see the same thing on the Montreal Cognitive Assessment Test, and I think that's because there was an improvement in the standard of care group. And it's probably a methodological error in even allowing the MoCA to be an outcome. It was an outcome in the pilot, but we didn't have the placebo group at that time. And there's been a fair amount of literature to suggest that the MoCA isn't a test that you should do every 3 months. It's just there's too much learning effects. And the typical patient who was in our study was usually more than just college educated. And so there was a lot of learning effects we think that happened. So let me go here. When you look at some of the markers of, let's call it metabolic and vascular health, you could see that rather than having adverse side effects from interventions, what happens is that people are getting healthier. So the hemoglobin A1Cs are dropping, BMI is dropping, systolic blood pressure is dropping, fasting insulin is dropping, homocysteine is dropping. So all of these markers, we're still in the process of doing some of the other immune dysregulations. So we should have TGF-beta and MMP9 in future data sets. But the point is that people's cognition is getting better, and their biological biomarkers are also getting better at the same time. When it came to the new biomarkers for misfolded proteins, it's a little bit of a different mixed story. And so p-tau217 is really regarded as the best and sensitive test for looking at Alzheimer's at this point. And that went down and was, had a p-value of 0.02, but not necessarily as strong as the cognitive results. What we were seeing, though, is some confounding, where what we've observed, and it hasn't really been reported in the literature, but we are going to report that in a separate piece, is that when people lose a lot of weight, their p-tau tends to go up. And it's likely because it's being released during weight loss, and so you have to look at p-tau in a different way. We did not have the resources to do PET scans on everybody before and after. That would have certainly helped us be able to determine that, but that was a budgetary constraint. So let me just talk about the path forward, and I'll be brief, and then I know there'll be time for questions. But again, part 3 was the results in the preprint. What follows really is my personal opinion. So at Rezilir Health, what we saw was the following when using these type of protocols. We could see that you could get a very high response rate in when patients went through this protocol, and clinically meaningful rates as much as 100% could be seen at some centers. Most patients reached meaningful changes within 3 to 6 months. The big negative prognostic factors that I see in practice is how much brain atrophy do you have on the neuroquant. And then if you have a high amount of immune dysregulation, that's just going to take longer to address. An open question in the study was, what's the sequence that you're going to do for patients? If you have 15 or 20 things you need to do once you see the labs back, are you going to do that all in month 2 or 3? And this is where there's, people had different approaches. Our approach was basically at Rezilir Health, we said, well, when people are getting their labs, let's focus on behavior change. Let's really get this right. Let's get everybody to understand some of those lifestyle interventions, obviously front-loading environmental, deeper assessment if needed. Then really get hormones right, get nutrients right. And then the big issue with toxicants, for me, it seemed like common sense now, but it wasn't common sense when we started the study, was to realize it wasn't a race to get to 9 months. You had to just do the right thing and figure out that patients were going to need care after month 9 and not try to rush things. So there was definitely, within the experience of the trial, there were some patients who I think investigators might have been too aggressive with detoxing, and then people took a step back. And so we tried to go very slow in some of these areas, like we would do in the real world outside of the randomized trial, but not use the randomized trial to kind of force what we had learned clinically. COVID certainly seemed to be an issue in terms of people getting infections or people having complications from that. We're doing further analysis to try to break that apart. So where I think we are is we've seen the important question answered, which is, if you try to do precision medicine, does it make a difference for people? And I think the answer is yes. But now, if you ask a lot of very relevant questions, which is, out of the, all of the interventions that you did, where's the 80-20 rule? What's this, the handful of things that makes the most difference? Well, the answer would be, well, instead of an $8 million study, it would be great to have 18 million or 80 million. You could start to break some of those things down, but some of those questions, it's hard to answer in an initial study. But I think they're very important questions, which is, how do these interventions interact? What can be eliminated? What's the right sequence? What's the role of monoclonal antibodies? Are they, I don't feel like they're necessarily mutually exclusive, but what could be done? A big question is biomarkers. So what we see with antibodies is that they address the biomarkers marvelously. The numbers all go down, but cognition doesn't improve. So could there be a role in which you address the root causes first, see biomarkers improve, and then go after use the monoclonals at a slower rate later? I think we don't know. These are all just good questions. And then really important is prognostic factors. I've certainly seen clinically that if you have a lot of atrophy, that puts everything in project status and a much more urgency. And so again, just understanding how those prognostic factors play out. I think those are all really important questions that we need to address. So here's my perspective on where we stand in terms of the landscape with using the Montreal Cognitive Test as kind of taking people into tiers. So if you have the Montreal Cognitive Test being 25 or above, which is, you're getting into subjective cognitive impairment and primary prevention, I feel this is from a policy perspective, a health systems perspective, I think it's going to be very cost effective to drive change using coaching, using AI in trying to get things as accessible and as inexpensive as possible, and just really getting prevention out there as an effective and low cost perspective as possible. I think once you start to get to mild cognitive impairment, time becomes important. And I think the critical variable, again, is doing enough of a laboratory evaluation that you don't miss things. So what we see, for example, in our practice is that when there are patients who have been seen by other clinicians and they might not be doing as well, it's almost always that the CIRSx piece is not being managed right, and that needs to be reevaluated. And so that's a critical component of the equation. I personally believe that once you have atrophy on the neuroquant, you've got to see that move in the right direction. We believe that hyperbaric oxygen is a great adjunct. I feel that the data from Israel is sufficient in a lot of these areas to allow for insurance coverage, but there seems to be a issue about whether a study comes from the US versus from Israel. But if you look at the Ephraides data on hyperbarics, they're doing sham hyperbarics, and it's high quality data. And so that if you have atrophy, you can add that. And then certainly the impact of some of the neuromodulatory therapies, in particular now something called transcranial magnetic stimulation seems to have about the same impact, Cohen's d of 1, and it's just there's a lot of new data coming out on that. It's not as durable, but again, this comes to like having a broad toolkit and saying how should that toolkit fit. I worked with colleagues at Better Brain, or was part of that effort that looked at the research literature on interventions for brain health. There's probably about 200 plus interventions now that have a positive effect in the literature. So we're not lacking for tools, but we are lacking for clarity around how to use the tools in the toolkit and which ones would really work. We've seen in the clinicians who are working with Dale that 16 tends to be a little bit of the hard deck. If once you go an Montreal cognitive test below 16, it's really hard to get improvement all the way back up to the mid-20s or so. You can get improvement, let's say from 16 to 19, but there seems to be at that point a bit of a cumulative damage. And so one of the challenges is, this can be a slow-moving train. You can oftentimes measure amyloid in the blood 20 years before Alzheimer's starts. So it's a perfect condition for prevention. But when the Montreal cognitive test gets lower, time becomes of the essence. And there's numerous case studies of people who have cognitive scores below 16 where this type of approach can absolutely improve quality of life. And so that's still important to have. I think the real question at this point becomes, how do we get this covered? And so I'm going to just talk about this at a very high level. This is a lot of what I personally care about because I want this kind of care to be available for everybody. I started my career after getting out of fellowship and, basically working in the federally qualified community health center world, ran a group of Medicare Advantage practices that were focused in the inner city patients. And so used to being in a high-risk group, and running a cash practice mainly because that's what's necessary for medical freedom at this point. But we can work to get this covered. And so what I do believe that some of the potential steps is to try to work with Medicare around what they have what's called a real-world evidence pathway, where potentially there could be 10 sites, 15 sites that have demonstrated effectiveness, and you make a deal with Medicare that says this can start to be covered at those sites. In exchange, we're going to actually get real-world evidence, and we're going to compare it. Maybe that can be compared against monoclonal antibodies, but that can get the endpoints that the government needs to try to improve this. I do believe in doing some preliminary health economics modeling is that if you take some of the standard models that are out there for dementia and you say you can push progression for just 5 years or 3 years, that this cost should actually be cost savings to the health system. And even though you may hear in the media that things are cost savings, it's very rare that any healthcare intervention actually saves money. But if you think about the resources, a nursing home in Florida might be $100,000 a year. Caregiving support at home, very expensive. And so if we can push this out, it will make an enormous difference, not only in quality of life, but if the healthcare system is just looking at dollars and cents, it'll be a very strong economic argument. I think the challenge just for implementation from the economics is that the people who are paying for nursing home care is not the same people who are paying for medical care. But I think that we can really use a health economics perspective to really force the comparative effectiveness. This should be a no-brainer, but because of some of the legal, political, and social issues that we face in how our evidence gets adopted, and I'm really looking forward to Scott's talk tomorrow because I looked at it in advance about sort of redefining medicine. Those are really the issues. But I think people do understand dollars, and I do think that this approach will really stand on its own merits when there is a dollars to dollars comparison between other alternatives. So so just where this leaves us is the following. I think that you guys should come out of this talk hearing that cognitive decline is treatable, it's preventable. I do believe at this point the approach is reproducible. Obviously, we need more research, but there's enough common components of interventions across a lot of different types of researchers that we need to really sort of up our game as health systems to get this to patients. I do believe that all people in this community and in other communities we want patients to be able to get this. And the way to get this is to really getting it to scale and to getting it to coverage. And so hopefully in the next few years we'll give better updates as we go down this pathway. Thanks for your time.